This is Mrs. Harlan. We're talking about Chapter 55, Care of the Patients with Stomach Disorders. And this particular picture here shows a bleeding ulcer on the gastric mucosa for you. So major stomach disorders. Inflammation of the gastric mucosa. Remember that the gastric mucosa is just your stomach lining. It can cause ulcers. They can be either erosive or non-erosive. Erosive just means that they cause ulcers. For acute gastritis, the lining heals after several months, but for chronic gastritis, this does not happen. Prostaglandins help provide a protective mucosal barrier that protects the stomach from it actually digesting itself, and this is called autodigestion. A break in this lining allows injuries such as ulcers, edema, things like that to occur. Then this is worsened by a histamine release and vagus nerve stimulation. Hydrochloric acid then goes back into the mucosa itself and injures the vessels. Then you get things like edema, inflammation, and changes in the epithelial lining. And remember I think it was chapter 54, we talked about those changes in the epithelial lining. Instead of being the normal squamous cell, they become the columnar type, and that's what sets patients up for Barrett's esophagus. So acute gastritis is just inflammation of that gastric mucosa after exposure to irritants such as the hydrochloric acid, smoking, alcohol, irritating food. This causes the mucosa to become thickened, and the membranes, causes the thickened mucosa membranes, and then it can have prominent folds. Those folds are also called rugae. Healing can occur in a few days, but if muscle is involved, then the patient may have hemorrhage. A chronic gastritis is a patchy, spread out inflammation process of the mucosal lining. The walls start to thin and then they atrophy. And just think about it, just something that is just really, really thick. And then just say like you have a really thick milkshake. And let's say you add an ingredient in there to thin it out. Well, that's the same way that happens with chronic gastritis. You have these really nice, thick folds or rugae, and then all of a sudden all this acid comes in, and you may have some alcohol or some smoking to help constrict those veins, and then all of a sudden it's thinned out and everything starts getting through those thin walls. The parietal cells, remember your parietal cells are your acid secreting cells, that function starts to decrease and your intrinsic factor is lost. Your intrinsic factor is very critical for the absorption of B12. Pernicious anemia can occur due to the lack of B12, and pernicious anemia and the lack of B12 is associated with the risk of gastric cancer. Okay. There are type A and type B. Type A is non-erosive. That means it doesn't cause ulcers, and it's inflammatory. It involves the fundus and the body of the stomach. Type B is your most common. Type B can involve the entire stomach or just the antrum. Type B is actually caused by H. pylori infection, which we talked about in chapter 54. The atrophic involves really deep destruction of the glands. You see atrophic more in the older adults. Abnormal tissue can develop into peptic ulcer disease and gastric cancer. In older people that were exposed to things like benzene, lead, nickel, or even the H. pylori infection is why you see more of the atrophic type gastritis. So peptic ulcer disease is just a mucosal lesion of the stomach or duodenum. It happens when the mucosa defenses become impaired and they can no longer protect the epithelial lining from the pepsid and acid. Indigestion is the most common symptom associated with peptic ulcer disease. There's a sharp burning or gnawing is what most patients will tell you they feel. It can also be described as a fullness or abdominal pressure. Older adults have more nausea and vomiting. Remember, your older adults don't have the normal symptoms. Patients may have a high white blood cell count and a low hemoglobin and hematocrit due to bleeding. Most gastric and duodenal ulcers are caused by H. pylori. They don't know why it causes it, but it can be believed from possibly contaminated food or water. The H. pylori bacteria causes cell necrosis, and it produces substances that damage the mucosa. Another thing to remember is H. pylori produces a substance called urease. That urease breaks down urea into ammonia, and then this ammonia neutralizes the acid in the stomach. Urease can be detected by blood work to confirm the infection, and H. pylori is a major risk for gastric cancer. Gastric ulcers develop in the antrum of the stomach, close to the acid-secreting mucosa. The pain for a gastric ulcer is located in the upper epigastric area, and it's localized to the left or midline, and it can be aggravated by food. The diagnostic test for pelvic ulcer disease is doing an EGD to take biopsies. And patients with gastric ulcers need to avoid your NSAIDs. That's a nonsteroidal. Because the nonsteroidals help break down the mucosa in the lining. Gastric ulcers are usually very deep, and they usually occur in the greater curvature of the stomach. The duodenal ulcers generally occur in the upper portion of the duodenum. They are very deep lesions that penetrate through the mucosa and submucosa into the muscle. The main symptom of duodenal ulcers is high gastric acid secretion. The pH levels are low because of the excess acid. Pain is usually to the right, at or below the epigastric region. Pain occurs 90 minutes to 3 hours after eating, and it often awakens the patient at night. With gastric ulcers, they generally have pain a lot sooner than 90 minutes. Stress ulcers occur after trauma or a medical crisis such as sepsis or a head injury. Gastric ulcers, if left untreated, can lead to stress ulcers. And also an MPO status can lead to stress ulcers. Bleeding is the main symptom of stress ulcers caused by gastric erosion. So this slide goes into how ulcers get formed. With the first slide, it says conditions favor the development of gastric ulcers. You have a normal gastric acid secretion. But you have delayed stomach emptying, so that means that the acid is staying in the stomach, the food and the other ingredients are staying in the stomach longer. You have increased diffusion of gastric acid back into the stomach tissue. So we all know that when that there are times that the acid comes into the stomach, they come out of the tissues into the stomach. The acid combines with the stomach contents, and then they go back into their normal tissues. So with gastric ulcers, the gastric acid actually stays in the stomach longer. With duodenal ulcers, you have normal diffusion of that acid back into the stomach tissue, so it goes back into the tissues like it's supposed to, but you have increased secretion of gastric acid and increased stomach emptying. So you're having a lot, even though the acid goes back into the stomach tissues, you have a lot more acid in there. And then the stomach is emptying at a faster rate. So with peptic ulcers, these are the most common complications are hemorrhage, perforation, and pyloric obstruction. Hemorrhage is the most serious. It occurs in patients that have gastric ulcers and older adults. Hematoemesis is coffee ground emesis or vomit. Melena is dark, tarry stools. And both of these occur in duodenal ulcers as well. And this actually shows you a duodenal ulcer there and a gastric ulcer. Perforation can occur with deep ulcers that wear away the entire thickness of the stomach or duodenum. These contents leak into the peritoneal cavity, causing sharp pain. The abdomen becomes rigid, tender, and board-like, causing a condition called peritonitis. Pyloric or gastric obstruction has a manifest with vomiting. Obstruction occurs at the pylorus, causing edema, inflammation, or a combination of both. Patient may get metabolic alkalosis from the vomiting along with hypokalemia. So two signs you see from peritonitis and from peptic ulcers can be metabolic alkalosis and hypokalemia. And this is a really good picture for showing you where your cardiac sphincter are, where the fundus is, your greater curvature, your antrum, and where some of these, like your duodenal ulcers and gastric ulcers, are more likely to occur. And there are also some additional symptoms on page 1130 for you. And this is basically the end of this specific chapter. This shows a benign gastric lesion. There's no sign of bleeding. You can tell it's just basically a white area, but they would do an EGD for this specific ulcer and take a biopsy. This is duodenitis. It's basically a superficial erosion. Remember, erosion is ulcer type. And you can kind of see a salt and pepper area in the middle there. If it is symptomatic, then it would usually respond to an acid secretion inhibitor such as Protonix, like a PPI. And this is a duodenal ulceration. It shows what they call two kissing ulcers. And you can see on the left-hand side there, you've got an ulcer, and then on the opposite side, on the right-hand side, and you can also see that there's been some recent bleeding on the one on the left. So this is the end of this specific PowerPoint. Please remember to review your case studies and have a good day.